identified the small liver lesion that was picked up on a nuclear scan that you're able to perhaps ablate it in the OR or take it out by minimally invasive techniques. You've got the smaller the lesions, the harder it is to find because you cannot rely on your sense of touch. Room size. We realized, I can remember the day we moved into those operating rooms about 12 years ago. My first impression, because we were used to operating in rooms that were about 400 square feet, and I said, oh my goodness, I think the architects have made a big mistake. They've given us rooms that are nearly 500 square feet. I mean, man, what a waste of space. And within about 6 months, we realized that, oh, were they crazy? I mean, we need 600, we need 700, we need 1,000. So we need more space. We need more power. I need a nuclear reactor to run the power drain. In fact, we have rooms that just the panels are sucking so much electricity that we've got things that trip in the middle of the case. So you got to be thinking about power, about storage, and room size. Okay? These are all of the things. We are now looking at intraoperative CT scan, hybrid room with CT scan, because this can be used in our spine surgeries to help plan where we're going to make the osteotomies. It can be used in thoracic surgeries to do radiofrequency ablation of tumors, orthopedic surgeons in removing and planning their cuts. Everybody needs some sort of radiology guidance, but that has to occur in an environment, a sterile field with all of the instruments that we need. So that is going to be something that we see. We were thinking for a while whether or not we needed a cyber knife. Additional intraoperative MRI, I think we're going to nix that for the time being. Fluoroscopic suites, ceiling-mounted microscopes, anything we can do to get things off the floor. It's a tripping hazard. We've got anything you guys can come up with to get things off the floor, we would be very grateful for you. But there's only so much real estate in the ceiling we found, and things have to move around. And you've got to be able to be adjustable from when you go to a minimally invasive and now you're opening the patient to get the equipment out and bring new equipment in. So these are the things that you have to think of. You need the flexibility in the room. Okay. Wall of information. You know, simple things like, at the time of timeout, I need to see the consent to make sure that matches, to make sure we're operating on the right patient. As part of our timeout right now, we have to make sure that all the health information systems in the room match the patient. In an ideal world, the patient would have a little RFID chip, and when they came in the room, it would automatically default to their records and their key images that the surgeon identified in the preoperative setting as the key images that you need at the timeout. But right now, some things are still paper-driven consents, and you're looking for the consents and trying to match a medical record number. The systems don't talk to one another, but they all have to be integrated on a wall of knowledge that you could review to make sure everything is accurate for that patient. Audio-visual, again, just like the struggles I'm having in my house to be able to go up to something and push TV. TV, you know? It's a problem because my son is now on the Wii, he turned that off, he took that to HCM2, and so now what do? Lyndon, can you come down and help your father turn on the TV? And he said, oh, no problem, boo, 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 change this, you've got that, change the plug, the power cord, and I've got the TV. I have absolutely no earthly idea how he did it, okay? So you can see the surgeon frustration. All we want to do is chest x-ray, chest x-ray. It's got to work. But nothing seems to work. Everybody will show you at their display how great it is, but you buy it and you put it in and you go, TV. I don't know. Anyway, this is going to be the subject of our panel discussion. Information technology. We are gathering a wealth of information in the OR. Fantastic images. We have visiting professors from all over the world. We have too many visiting professors from all over the world in the operating room. Wouldn't it be great? In fact, the nurses have a term for the visiting professors. They call them bioburden. So, wouldn't it be great, through technology, if we could get the bioburden out of the OR because they're already crowded and put them in a little room off the OR and they could enjoy high-definition imaging, right? Boom, teleconference, bioburden. Boom. We are hoping for it. You need a central server because these images we can use for teaching. One of the big missions of MD Anderson is we want to teach, we want to get better, we want to show, we want to display the images. Right? It should be save, edit, simple, PowerPoint, on the plane, give a talk, right? It's up to you. Hands-free communication, all right? The old ORs at MD Anderson, I was talking about that, analog phones on the wall. Talk to pathology, put me on speakerphone. Hey, your margins are negative. Oh, thank you, margins on Joan negative. Now, digital phones in the OR, pathologist calls in. What did you say? Oh, margins are. The digital phones in operating room environment, they're picking up all the, you can't hear them. So everyone's yelling. Can you believe it? We're making advances. I can't even talk to the pathologist. I got to scrub out and walk down the hall. What did you say? Margins negative. Great. But that is where we are. We can't even communicate. There's so much background noise in the operating room. We need larger rooms, ceiling mounts, floor drains and clean roof, and we need lockers for storage of equipment. So this is our present footprint in Alkek. This is our biggest room. This is the one, the picture I showed you at the beginning. That was room 6. Room 6 is 567 feet, but we are going up to 650 feet. Now things that and this is where we worked a lot with virtual reality, mock-ups, looking at things. How do we best serve the needs? So we looked at 650 feet in a square orientation. We looked at it on a rectangular orientation, and we looked at it on a diagonal. And actually, I think we've come to the conclusion that we want to go on the diagonal because it gives you a lot more ability, because as you're operating, more and more stuff comes into the patient, so it's more or less like an oval that comes around, and if you turn it on an angle, you get more opportunities for the anesthesiologist to work and the nurses to work. So we're going to try that out. Now, one of our concerns is surgeons, like architects, we like everything lined up. So if you walk in a room and the patient's on the diagonal, is that going to make some surgeons feel kind of funny? So now the architects are going to have to put some straight lines on the diagonal so everything kind of looks like it's all lined up, right? Again, that's up to you. Again, storage. If there's one thing, please remember, storage. Okay? 6 new ORs on the 5th floor. All the other things that have to be close by. Our frozen section at MD Anderson is absolutely critical. Surgeons go, we sit with the pathologist. Wouldn't it be great one day that we don't have to scrub out and we could actually look up at a viewing screen and they could show us where the margin was positive or close, and the images could come back and we could learn right away and we could dialogue? Wouldn't that be great? It's not there just yet. We need a recovery and PACU beds that are interchangeable. So this is our present footprint here. This is where our recovery room is here. And we're going to use the recovery room as a storage. And then move the recovery room here. We're going to use our Lutheran. For those of you who know MD Anderson, this will be our intake. Again, patient flow, come off the elevator, come here, get dressed, go to the recovery room, go to the operating room, back to the recovery room, go to phase 2, go home. See, isn't that beautiful? It looks like it's going to work, all right? So this is Berkhold, who just were very good and received our recent bid. Technology, it's great, eh? Oh, God. Pretty sure that's it. Mr. Scruff, where did I go? Don't you love it? And we practice and we practice. There you go. So we use 3, this is those six rooms. There's the intraoperative CT scan. I'm a little worried. I see a lot of people sitting down in this operating room. I don't like that. There you go. So you can see storage there. And there's patients, second level. You know, we've spent an inordinate amount of time looking at where we're going to put our lights and our booms. It's absolutely critical. I mean, we've had some bad boom experiences, I should say. Would that be safe to say, Lisa? We've had some bad boom experiences, and that